Welcome to Let's Talk About Mental Health. I'm Nels Kloster. I'm an addiction psychiatrist and I work in Southern Vermont.
And I'm Robert Stack. I'm a licensed alcohol and drug counselor, a licensed mental health counselor. Good evening.
And as a reminder to our viewers, for comments or questions, you can contact us via our Facebook site or email, facebook.com/letstalkvt, or for our email and text, questions@letstalkvt.com. Yeah, and tonight we had a question from a viewer, and then, as always, we were intrigued by some current events and want to talk about those. In this case, they pertain to, well, I mean, mental health and addiction in particular, too.
Yep.
Yeah. So the question, I'm wondering what sort of therapy, if any, might be helpful in overcoming a long-standing PTSD aggravated by intermittent depression.
Right,
Yeah.
and so when I first saw that, first of all, thank you for sending in the question. It's always great to get those. You know, my goal from the very beginning, when we first started doing this show, was to help one person, to make it worthwhile. And it's been great doing this show, actually. I've really enjoyed it. And I'm hoping that it's been helpful to some folks. And so thank you for those who have been watching. Yeah. So on this one, but my first reaction to it when I read it was that it is, well, it's so, when I learned my training, if you will, PTSD, post-traumatic stress disorder, as you know, it was put on the books. I think DSM, it was put in there for veterans. And then I noticed it sort of being co-opted by, not co-op, but by people who had the same symptoms, but were victims of some traumatic injury, psychological, sexual, physical, childhood issues. And so it became a little bit of both. And I've never had a good way of knowing. I knew people who went to the VA down in Northampton or White River Junction, and they received different types of treatment there, talk therapy, different stuff. And this goes back 20 years at least, right? And so it's just hard to know what is the best therapy for post-traumatic stress without knowing what the stress was. And even having said that, the current Veterans Administration has a number of people coming back struggling with post-traumatic stress disorder. And I know they're trying different methods to treat it, both a combination of talk therapy, medication, and even some what do you call it, virtual reality, different experiments to deal with this. So I don't have a great idea how to answer this question without knowing more about what the PTSD is, because I think on some level it really changes. Like rapid eye therapy. Yeah. Anyway, go ahead.
Yeah. No, I think so. Maybe we sort of approach this generally because, as you were saying, we know PTSD. I think that the term was coined from work with Vietnam veterans, and before that, you talked about sort of battle fatigue. I think it was in World War II, shell shock in World War I, and even back in the Civil War, I believe it was called soldier's disease. So the idea is we knew with these very intense combat situations and threats of death there, that you could have this, these reactions. And I think too, in a way, this is again part of the focus with the diagnostic statistical manual. Always seems to be what's wrong with me. What label gets applied, and I really want to make the case here that, especially with PTSD, I think a more healthy way is looking at what happened to you. Because when bad things happen to us, when we're threatened in a way we're not supposed to, whether it's a sexual assault of an adult or a child, or the threat of death from being on the battlefield, we have certain reactions that occur, and that we expect to be present for some time, days, weeks, maybe even months in the immediate aftermath. And people will tend to, and so this is the clusters of PTSD as they've been termed, with reliving phenomena. For example, flashbacks, nightmares would be considered examples of reliving the experience. It intrudes in your mind and you can't keep it out. There are then avoidance symptoms as well. And you can almost simplistically look at that as the people, places, and things that remind you of the trauma or are associated with it. And then the arousal symptoms. You can't sleep, you're on edge, you're looking over your shoulder, you're just very much in a fight or flight state. And it's when these normal reactions to a traumatic event occur and they don't go away that then we use the term post-traumatic stress disorder. That then it becomes more and more problematic and more intrusive in people's life for the long term.
Yeah. And it really varies. And I mean, again, I'll just say, it's so hard to know. On a personal note, I've shared this with you before. My father was in North Africa and then Sicily and then Italy in the army. And I don't know how much it affected him, but I know it did. And there were certain things that were sort of, well, you just wondered about, like, how he dealt with it. Brokaw wrote The Greatest Generation, but he's right in the book, he talks about men that had nightmares every night and what people saw in the war and what they did in the war. So there was those war, and then Vietnam veterans had their own thing. I remember, men that I worked with when I worked in the hospital, struggling, living on the street, wearing their fatigues, hanging out in Northampton in the downtown, anyway, and then I remember the first Gulf War. I mean, that was one way. That was with the senior Bush president. But then the second time we went in the Gulf, and now we have people going through multiple tours. So again, I don't know if that's really what's going on here, because I think she mentions long-standing PTSD. So, and I don't know if she's talking about herself or her partner or someone in her family or something. But one of the best advice, and I think I've heard you give it here, is really, well, can we help you with the symptoms without going to what the original trauma was? What are the symptoms that's struggling with you now, and what can we do to help those symptoms
but
now?
Before we do that, though, I want to, there was some resistance too for a while of applying the label of PTSD to civilians, right? So people have experienced physical, sexual, emotional trauma. And, most often the sexual and the physical traumas would be considered, misuse would be considered to lead to PTSD. Because they thought that was of a different nature. And now people, particularly one researcher, Bessel van der Kolk, are arguing that there really needs to be recognition that this is a different experience, but still equally as important, and definitely a PTSD type of disorder and response. So regardless of where the trauma comes from, if you're fearful for sort of the integrity of your body or fearful for your life, whatever the setting and whatever the type of trauma, this is a valid reason to use the organizing theme of PTSD. But yeah, there's in the VA, I mean, as we talked before the show, neither one of us is particularly practiced or aware of, say, the more sort of intense or in-depth advanced work on PTSD. But there's a framework around this. And one model that I've heard that sort of makes sense to me and seems to resonate with people that I've worked with is safety is very important. And the first safety, of course, is to get out of that traumatic environment. So whether you leave the battlefield or like the work with the Women's Freedom Center and other centers that work with victims of domestic abuse, you have to get out of the home, or you can't do any work around PTSD because you continue to have the exposure and the violence that's happening there. Another sort of safety is with the relationship with the therapist. It needs to be looked at, just like we do other recoveries, as a long-term process. And I mean, I would dare say, if you go and see somebody with the intention of working on PTSD, and they want to dive into your experiences and dive into what happened and have you go over that, I want you to get up out of your chair and leave that therapist right away, because that is not the right way to start work on trauma. Now, with veterans and some of these exposures, there might be a little bit of different advice for that, but for the most part, you need to develop a relationship with the therapist, because the first steps are going to be to work on the symptoms. Right? How do you deal with that distress? How do you deal with the anxiety and the arousal that comes from reminders or just comes from the course of your day? And then two, how do you deal with the nightmares, flashbacks, and those sort of things? So basic coping skills are what you should be learning the first time. I mean, so in the earlier stages. And a safety around your emotions as well. There needs to be a rhythm to the therapy session, that you have a chance to sort of cool off towards the end of it, sort of ground yourself and get sort of ready for going back out on the streets. And also, this is where treatment around drug and alcohol issues is a very important piece of this, because if you don't have your sobriety under control, but you're still using substances to turn up or turn down, then you're not going to be ready to handle this. So you don't have enough control of your emotions in the case of active substance use to be able to do productive work with your traumas.
Right. And I wonder now, PTSD is almost, you hear people making their self-diagnosis of that, and you hear people saying they're having, and one of my concerns, and I'm a veteran, and we have a veteran outlook over here near Exit 1 in town here, and I go there. But one of the things that I learned when I was working in the hospital, I would work with some veterans who were so angry at the military, and at the VA system, they wouldn't use them.
Right.
So, it's sort of, some people are utilizing services, and yet I'm always worried that there's some, like some of the Vermonters were in the reserves who went over there, and now they're come back, and now they're no longer in the military community, they're back in the civilian community, and many of them might be suffering, and they might be suffering from, but substance abuse is masking some of it, or it's getting worse, or they're, God forbid it's affected their marriage, they're getting divorced, they're having outbursts of violence, whatever that might be, and by now they could, you hate to hear this, that, some of the veterans are ending up homeless, or they're ending up without jobs and all that, and it's such a bad cycle, So I guess that I'm going to repeat what you just said, and that is that, if, I would say, make sure that they're seeing some mental health professional. If you think someone has PTSD, make sure they go see somebody, get the diagnosis, talk to somebody. And then therapy could differ. It could depend upon what the trauma was, could depend upon the symptoms. Could be a case of a combination of medication. And I know when I used to work with some of the men, veterans, Vietnam veterans, I would tell them about the three-legged stool. You want to have all three. You want to have sobriety, recovery. You want to have therapy and maybe medications. And it's the idea that you can get away with two of them. Maybe sobriety and therapy, or maybe medication and therapy. But it's ideal if you have all three. It's a more stable, more secure thing. Yeah. The other thing, if you don't mind, and it's this depression. What's the diagnosis? Who's making that depression? Are we talking about sadness? Are we talking about suicidal thoughts? Are we talking about not getting up out of, you know what I mean? And again, intermittent, is it a combination with manic behavior, or is it something else going on?
Yeah.
So,
or then too, oftentimes in psychiatry, there's this tendency to apply as many diagnoses as possible. And it might very well be too that as part of the sort of symptoms that we've outlined being part of PTSD, that there's this feeling or perception of there being intermittent depression might actually be a sort of, a part of the waxing and waning of the symptoms of the PTSD as well. We see so often that certain times of year, which are, say, a reminder of the trauma itself, for example, bring a cycle to the PTSD and could maybe be an explanation for the sense of depression. And it might be part of the PTSD itself. I don't know who people are watching this or when they'll see it, but this, my heart goes out to whoever this is, whether she has PTSD or he has PTSD, or a loved one has it, living with somebody with trauma, who are survivors of trauma, can be very challenging. And this idea about the depression seems to come and go.
And if you know somebody with depression, we're going to talk about the suicide risk in some of the later surveys. We'll talk about that a little bit later. But this is a member in our community who sent this in to us. And I guess if this is not about you, if it's someone that you love that has post-traumatic stress disorder and suffer with depression, I would also recommend that family member go and talk to somebody,
right.
Whether it's a counselor in the church, mental health counselor, a social worker, but don't be doing this alone.
Right.
You might feel overwhelmed by it, you might get scared by it. Not sure whether you should talk about it or not talk about it. I mean, this is somebody who wrote in a card, sent us a card anonymously, and it's all right. I'm just saying that they're reaching out, and I suspect that it's really about someone they know. It might be about themselves, but I suspect it's about someone else.
And I would suggest, too, that this is not simply a medication issue with PTSD, and to be cautious about the use of medications. Mm-hmm. Very common and safe with helping the symptoms. Antidepressants are commonly used. Also, there's some medications that work at the fight or flight receptors to help with nightmares, for example, mm-hmm. and fearfulness in the daytime. But I would urge against accepting benzodiazepines,
right.
Ativan, Xanax, Klonopin, Valium. The VA is recommending their doctors to be judicious or to cease prescribing these for trauma. Mm-hmm. It's just that while they're very effective at relieving that discomfort, over the long term, there's more risk than benefit, and it does not seem to be a first-line treatment for PTSD. So I had to get that in there. Right,
and the other thing is that I have known some folks who were suffering from physical, sexual abuse, and one of the great things I've seen, and I actually got to witness it over a period of time, was this transformation from being victimized and feeling overwhelming and dirty and ashamed, whatever way you want to think about it, who really at some point began to feel more like a survivor mm-hmm. and recognize that they've gone through this, they couldn't change it, it wasn't about them. It was about the perpetrator, and really, in some ways, successful therapy was really transformational. I mean, really successful.
Yeah, developing a new identity in the aftermath of the trauma.
Exactly, and so there is. I don't know what is the best therapy for this person. I mean, I couldn't recommend. I wouldn't say one way or the other, but I do want to say that there is successful therapy for both of these things, for treatment of depression and for PTSD. But it does vary by individuals, and finding the right therapist and finding the right relationship with the healthcare system, mental health care system, probably is most important. Because symptoms come and go, they get worse, they get better. You have and to repeat what you said, be very mindful of substance abuse. One of the problems that I have working in the field of addiction, alcoholism, was people who would say that they're self-medicating their disease. And when they do that, they give themselves permission to use, because who would deny me my medicine? And that can be a real trap. You feel like you're treating one illness, but what you're doing really is you're getting a co-occurring illness, if you will. Now you're going to have two problems. Now you're going to have an addiction problem or an alcohol problem, and you're going to still have the PTSD. It's not a very successful treatment, and so I can't tell you how many times I've heard people use that term, self-medicating of something like this. It's not medicine, and it's not helpful. It may give you some temporary relief from some symptoms. Instead of falling asleep, you pass out. Perhaps that's helpful, but it's not the answer. And when we talk about some of the suicide risks, we're going to talk a little bit more about that later.
Okay.
Okay.
Should we get some current events then?
Yes.
Yeah. I think this one really intrigued us. Up in Vancouver, Canada, If folks were, I think they have had injection sites up there, one of the relatively few in North America, actually maybe the only one, and where people with addictions could bring their own drugs and were given clean needles.
No,
before this.
Okay, before this.
They were
right,
given,
right.
they were given
Yeah,
clean
yeah.
needles,
Yeah.
and under medical supervision, they were able to inject their drugs.
Right.
And the idea behind that was that, well, it was decreasing harm.
Well, they're trying that in Europe. I mean, we talked about that in France and other places. These are safe sites, but they're also a window into getting medical help or care if you want it.
There's like 90 of these in the world, and they're of course located not on our continent. And so now in Vancouver, a new place, the Crosstown Clinic is taking this a step farther, and they are actually prescribing the heroin that people are injecting.
That's right.
Yeah. So that's so again, that's sort of taking another step, and a lot of people are having a reaction to this.
That's right.
Right. And then you and I, as we discussed this before, there are really, there's a sort of emotional response to this, on the one hand, and then what might be considered a more analytical, scientific approach. When I say that, it sounds like I'm setting up for there being a right and a wrong, but there's an economic and a health perspective on this that is different from that sort of initial emotional response that most people have of, oh my God, what, are you kidding me?
Right, but I did have that reaction, and you and I talked about it, and it's like, okay, where does this stop? We're going to give them heroin, and we're going to give them a little room to shoot up in, and they come 3 times a day to shoot up their heroin. Enough already. But on the other hand, they do say that these have to be individuals that have failed, like a methadone program, at least 2 other programs, and they're part of a research study and everything. And it's just the idea, I guess, I'm struggling with. The idea of giving them heroin to shoot up, and yet they have obviously anecdotal people they interviewed, 55-year-old, 65-year-old, 45-year-old who've been struggling with opiate addiction all their life, and they're saying this is great. I go in, I do my and they had to fail the methadone program. They had to actually try methadone, and then and one of the reasons you like methadone is it has a half-life, and you go once a day, get your dose, and you get the next day's dose. But this is a program, with heroin, it goes in and out, and they're going to have it 3 times a day. To me, what struck me about it, this was an article in the New York Times, was just this idea, and I know Vancouver has been tried lots of different places. I think they were probably one of the first to have a safe place to inject.
Insight was the name of it. And as you can imagine, with conservative politics having taken its force in Canada as well, there's a lot of attention to the work at Insight with the offering needles. And so that program has had a lot of scrutiny, a lot of research done on it with publications in the journals of JAMA, the Journal of the American Medical Society, Lancet, which is a British equivalent, and folks are writing that this is good medical care. It saves lives, and it's less expensive.
Right. But I remember when we were trying to get hypodermic needles, and the only reason we were doing it was to help with the AIDS epidemic, stop and get clean needles. And we set up needle exchanges, and I was on the board of one here in Brattleboro that was part of that. And then before the show, you were telling me, I don't know if that's even out there
I don't
anymore.
think we have needle exchange in Brattleboro anymore.
Yeah, and some pharmacies don't give them out anymore. I mean, I remember advising counselors saying, I think you can go here and go to that little booth and tell somebody and see if you can get.
If I'm wrong on this, please
No.
tell us.
So I just want to say it's everybody's sort of trying to figure out what do we do about everybody doing heroin. I mean, what do we do? And Vancouver, you can make your judgment about how you feel about it, but I was sort of joking with you. That's on one coast. Now on the other coast, we have another example.
Yeah. So we, but one.
Yeah, go ahead. Yeah.
Wait, no, let's.
No, go ahead.
The governor of Maine.
The governor of Maine.
Do you want to read this quote?
Yeah, go ahead. Go ahead.
So this is Paul LePage, who's the governor of Maine. our neighbor, and he vetoed a bill for so Narcan, naltrexone, which the state of Vermont has been doing a great job of getting around. We finally have in all the counties in Vermont, and this is the overdose, the overdose antidote, as people have been calling it, and it's saving lives. And what he said is it does not truly save lives; it merely extends them until the next overdose.
That's right.
Yeah.
And so, but
I got strong language for this guy.
I know, but I think it speaks to the frustration on some level. I mean, people like, and maybe it's naive, maybe it's terribly judgmental, but it's sort of like, cut it out. Yeah. You know what I mean? Like, well, over here on this coast, we'll say, well, look, we'll give you a room and the needles, and we'll even give you the heroin. You stop by 3 times a day, you know? I mean, you know, and we'll give you some place to shoot up heroin, and it will save money. It will cut back on disease and all kinds of stuff, and you can have a normal life shooting heroin every day.
So what's not to like about that?
I don't know. It just bothers me.
Yeah, and it takes some time. I mean,
but then I hear the governor, and I respect him. I've seen him, and this was a liberal TV station. They were sort of making fun of him on some level, but except it's not a funny idea. But his reaction was, you know, it's not curative. It's not really stopping anything. And that we do know this, that people are getting Narcan, they're getting injections. I read in the Boston Globe that they had to warn people that sometimes the addict is going to get angry if you put him into withdrawal. But
you and I have both met people who were so frightened by the fact they'd almost died, and that they were rescued by this Narcan, that they were on the phone. They were looking for treatment.
Yes.
There's so many people we meet. And I think it's just maybe that, maybe some has been, as a physician, some things have been trained out of me, maybe, that like squeamishness. But we know that we have addicts or people who use drugs in our society. And if we do nothing, they still cost us money.
Yeah.
Right? And so now if we do these things, they cost us less money.
You know, I don't care about the money. I mean, if you just say to me, you don't deserve to die because you're getting high, I might agree with you.
Yeah.
You know what I mean? The money argument doesn't work for me, quite frankly. I like it, you know, it's like when they say we put them in jail or whatever, I don't care. You know, the money that we spend on weapons, on lots of things that we spend money on, that I don't worry about the money argument. I just worry about, like, what are we doing? Are we really being helpful? And obviously I don't want anybody to die, but I you know, when I talk to you about this, and you know, here it is on one side, Vancouver, the West Coast, and they're doing what they can. They're going to see if that works. And that's great. I mean, I'm all right with it, I guess, on some level. And then over here in Maine, on the other coast, is this governor's just saying, but it's not the answer. And I'm really upset. And they're still addicts. You know.
But his responses to this was, well, they basically wanted to have more police involvement. He wanted to stop drugs from getting into Maine. He wanted to sort of preventative messaging about, you know, don't do drugs, and that kind of thing. It's just it's short-sighted. What I would say to him is, why don't you make Maine a place where people thrive and can live healthy, productive lives? That'd be the best prevention that you could give. And this stuff here becomes superficial compared to that. The reason why I bring up again, because we don't necessarily have sort of a social net. We don't have that kind of a care system here. So often, if you don't argue, if you just talk about doing the right thing, it's seen as sort of socialistic and not cared for. So I bring up the money because that's one more dimension that might be able to get some conservatives and some misguided politicians like Paul LePage to sort of look at this in a way that is actually good for the economy too.
But I wanted to point this out because I've worked in the field for 30-odd years, and I know a lot about recovery, addiction, and stuff. And there's parts of me that I still don't get this. I don't know what the answer is. I don't know what the right approach to take. And I just want, and I'm not making fun of the governor.
Oh no, but 30% of the people who come to this clinic get into, it's called detox treatment, and there's a decrease in 70% of, I think it was like overdose deaths. So That's the reason it is.
Okay. And we're going to have to cover this thing about suicide rates and depression next week.
Yeah.
Or the following week.
We got too excited about these things.
Yeah.
We just did.
All right.
All right. Well, great. Thank you.
Thank you.